So it's a little bit different aspect of opioid abuse. And I'm not going to repeat how serious opioid abuse has been. So I'm just going to skip this slide and then go to the economic burden. So opioid abuse imposes significant economic burden to our society. In 2007, the total societal cost related to opioid abuse was $55.7 billion. And 46% of the cost was related to workplace, such as premature death and loss of employment. And 45% of the cost was related to health care, such as excessive use of medical services and prescription medication. And 5.1 billion was related to criminal justice, such as correctional facility and policing. And economic burden has increased in 2013, which Dr. Bresling already presented. So opioid abuse has cost the insured about $78.5 billion, and this is only for the direct healthcare cost alone. Does not account for other expenses such as workplace and policy and policing. Okay. So as Dr. Updike mentioned about comorbidities in this population is highly prevalent. So opioid abuse is not a standalone condition. Many people with substance abuse or opioid abuse have multiple comorbidities, including both physical and mental conditions. And those comorbidities often compromise the treatment outcome of primary condition if left untreated. And the problem with people with comorbidity is they go to different providers for different reasons. And oftentimes providers do not really communicate to each other. As a result, people with opioid abuse tend to overuse the healthcare services. And research evidence already suggests that addressing substance use and concurrent health conditions together can improve both physical health and substance conditions. And Affordable Care Act gladly is still there. Also incentivizes and promotes better care conditions between providers and the use of multidisciplinary team to address individuals' total health care needs in a more efficient and cost-effective way. So what do we know about people with opioid abuse? We know they have multiple chronic conditions. And we know that our healthcare system is not doing a good job in integrating care for this population. But what we don't know is how those people actually utilize our healthcare system and how their current condition might play a role in their use of healthcare. Sorry. So the purpose of, I need some water. So the purpose of this study was actually to describe healthcare utilization in people with opioid abuse and try to understand how their utilization pattern is different from people without opioid abuse. And then try to identify and characterize their health utilization patterns. So we used Medicate, New York State Medicate data from June 2014 to June 15. This is 1 year data, and we obtained it through New York State Medicate data warehouse. And we evaluate individuals of all ages with regard to their inpatient, ER, and outpatient claims in 8 counties located in Western New York. And this is the process of identifying those individuals. So we identified 448,000 individual unique patient record, and among those unique patient records, we found that 312,000 individuals have any claims data during that study year. And then among those people with claims data, we identified 5,096 individuals who we identify them as opioid abusers. And here are the codes that we use to identify those individuals based on ICD-9 codes. In addition to coding opiate abuse, we also code chronic comorbidities. And the major chronic diseases, there are 12 of them, based on the previous study that done by Dr. Huner. And a major chronic condition is defined as having a systematic complexity in the body. And we also code mental health disorders, and in terms of specific type of mental health disorder, and then count the total number of mental health disorders those individuals have. And then we also coded substance abuse in a similar way in terms of types and number of substance abuse. And we also coded smoking and chronic pain. Now, I have to say that coding chronic pain is still work in progress because there are so many codes in the ICD-9 system related to chronic pain. It takes a lot of our time, so we have not yet coded all the diagnoses related to chronic pain. But so far, we have 4 codes that we use to identify those people with chronic pain. So, for our first research question is to see if there are differences in terms of healthcare utilization between people with and without opioid abuse. As you can see, people with opioid abuse have significantly higher utilization across 3 types of services: inpatient, emergency room, and outpatient. On average, people with opioid abuse utilize ER 3.5 times a year, and outpatient about 7.5 times a year. So they are significantly higher than those without opioid abuse. In terms of comorbidities, as you can see, all red. So they have much more comorbidity than those people without opioid abuse. And those comorbidities are mental health disorders, specifically depression and anxiety disorder. And even we haven't finished coding chronic pain. If you look at chronic pain, prevalence of chronic pain is also very high in people with opioid abuse. Our second question is to see if there are patterns that we can identify for those people with opioid abuse in terms of how they utilize healthcare system. So we only look at opioid abusers for this question. We use cluster analysis to identify patterns, and we found 3 distinctive patterns. And we named them based on the cost effectiveness of healthcare utilization. So based on the literature, use of outpatient is considered high value use, and use of ER or inpatient is low value use. So based on the definition, we named these 3 groups. Cluster 1 is group number 1, has 30 individuals in that group. And this 30 individuals is going to be something that we will talk about in detail. So they have very high rate of ER and inpatient use, and moderate rate of outpatient use. Oops. Oops. And then cluster 2, we call it as mixed value use group because they have moderate rate of inpatient and ER, and low rate of outpatient use. Cluster 3, we call them as high value use because the use of inpatient and ER is low, and then the outpatient use is high. So here are the numbers of their actual utilization. So if you look at low value user cluster, and those 30 individuals within the year, on average, they use ER 97.9 times, which means they went to ER every 3-4 days. And then we have 2 individuals in this low value group. They have more than 300 ER claims in that year, which means they went to ER almost every day. And their inpatient utilization is also very high. In terms of comorbidities across 3 groups, you can see that low value user group have high comorbidities in terms of types and numbers. So on average, individuals in the low value user group have about 1.9, almost 2 other types of substance abuse. And this consistent with what Dr. Updike mentioned, that people with opiate abuse have other substance abuse. And in this particular group, they have about 2 other types. And not to mention other mental health disorders. So in terms of number of mental disorders in this group, about 83% of those people in this group have at least one type of mental disorders. And this rate is much higher than the other 2 groups. And we have a lot of comparisons, but you can see the people in this low value group has many comorbidities. So let me summarize the findings. So people with opioid abuse have significantly higher utilization across 3 types of healthcare services compared to those people without opioid abuse. And individuals with opioid abuse have also significant higher mental health comorbidities, substance use disorders, and chronic medical conditions compared to those without. Those 3 clusters that we identify can actually help categorize demographic profiles and comorbid conditions in people with opioid abuse. And opioid abusers in low value use group had excessive healthcare utilization, especially excessive ER use. And people in low and mixed value groups also have multiple comorbidities that require complex care. So the high rate of coexisting mental health, substance abuse, and chronic condition in people with opioid abuse might result in high utilization of different types of care. So we fail to address comorbidities might result in unnecessary healthcare utilization and may also compromise the treatment outcomes. Now, all these odds indicate a greater need for coordinated and integrated care in this population. Limitations, we only look at 1 year data. And this is as far as we can go because data coding and data mining takes a lot of time. And then we, of course, we want to look at the long-term outcome and how those people change over time in terms of their use of care. And just for my personal opinion, those people in the low value use group might die early compared to other people. And then we don't have specific information in terms of their purpose of visit. And this is our next step to do is to look at what exactly utilization going on in terms of if they actually use substance abuse treatment and how frequent they use substance use treatment services. If those services are actually effective, and we know that those rehab 28 days is not actually working. People get in and get out and come back again. So this revolving door syndrome is really critical. Okay, conclusion, so despite the limitations, our study indicated healthcare utilization pattern in people with opioid abuse is costly. And we identified 3 value-based utilization groups that characterize different comorbidity profiles that can be used to inform a better care integration and coordination for this low-income Medicate beneficiary with opioid abuse. And of course, more research is needed to better understand the specific and complex needs of this population. And I would like to acknowledge my team members. Without them, this study is impossible because it's really time-intensive. And Dr. Sabrina Kasushi is here. She is really the person handling all the data mining. And it takes very long time for her to really put all the data together. And hopefully we will continue to work on this data set and we'll be able to publish the results. All right, I think I finished in 10 minutes.